So I believe we are recording now. So for people who are asking questions about recording, we'll see how that goes. So before we get like too into things, we'll just kind of talk a bit about how today will run, and we'll set some basic ground rules. So first of all, this is my first Zoom teaching session. I've got two screens open. I think you guys can see me as a thumbnail, and you can see me sharing my screen of the presentation. I also have some notes up on another screen. So I'm gonna get my wires crossed probably like half a dozen times. So just bear with me. I'm not the biggest tech guy, but I think this will work pretty well. So we'll kind of jump into things. So how things are gonna work. So it'll take about 30 minutes, I believe, to go through everything. So it won't take too long. We have lots of time. We're gonna cover the topics of hypertension, edema, and then also talk about diuretics. Within that, we'll talk a little bit about basic nephrology physiology.
In that,
What do you want to say?
other one like format and substantive revisions.
Sorry, I can just hear some people talking, so just make sure that your mic is muted, sorry. So when it comes to going through the slides, so yes, so I want you guys to be engaged. We'll probably use the chat function to do that as best we can. Once we get closer to the end, as I said, it'll probably only take 30 to 40 minutes, depending how many questions you guys have throughout to get through everything. So I'm happy to have more like of a discussion and more of an open conversation, even with like some things that just we kind of peripherally touch on through the presentation. But during the presentation, if we can keep the messages just or the chat as the questions, and I'll try to keep that up and go through those as long as we go, okay? And if anyone's having any technical issues, I probably won't be able to fix it as I just said, but I'll do my best. So just pull that up in the chat as well. Okay, so we'll just jump right into things. Okay, so now this is me advancing two screens at the same time. Okay, accomplished, nice. So when it comes to edema and hypertension, I've grouped these two together because essentially they're most commonly caused by the same problem, and that's elevated blood pressure. So when we traditionally think about the definition of elevated blood pressure, so the one other thing before we get into this, I just want to say as well, I don't know if you guys have been told this before, but the chat is monitored or not monitored, but can be seen by hosts, even private messages. So I just ask you guys to keep it professional and avoid putting any private message in there that you wouldn't want seen by Dr. Bess Uni. I'm not gonna look myself, I'm not too interested, but just so you know. Okay, blood pressure. So blood pressure, you can have problems with your blood pressure, and really there's two sort of phases of that. There's arterial as well as venous. So hypertension is arterial blood pressure that's elevated when we traditionally think about it, whereas venous blood pressure, as it gets elevated, we actually have the consequence of edema. So when you're thinking about blood pressure, I just want to break this down into like the mechanical factors that are contributing to blood pressure in the most basic essence. So really the two things from a physical standpoint that it comes down to is how much volume of fluid you have and how big of a volume of the container that fluid is in. So when it comes to arterial hypertension, remember what the role of the arteries is. It's to bring blood and nutrients carried by that blood as quickly as possible to tissues. So you need a really high pressure system to be able to allow that to happen as quickly and as efficiently as possible. So when you think about this high pressure system that's being used for perfusion, really the cardiac output when it comes to blood pressure plays less of a role. It can still have a significant role, but it more so has a role when our blood pressure gets too low. So when you guys think of cardiogenic shock that you learned in the last course, that's really the volume of the fluid going into the system not being sufficient. But when we think about hypertension in arterials, cardiac output plays less of a role. You know, you can think of some examples like, say, someone who does stimulants, like methamphetamines or cocaine, that can increase your cardiac output and contribute to your hypertension. But again, the biggest contribution of those medications and in general is really about how big the container is. So really it's about how much vasoconstriction do you have going on in your arterial system. And really that's controlled by a couple of main things. First of all, it's just your sympathetic tone via your baroreceptors and your sympathetic nervous system responding to that. So the main sort of signalers in that system would be your catecholamines. So that's your adrenaline and noradrenaline. So those obviously have a significant effect on vasoconstriction. And then also the new system that you guys are learning about, and we'll probably touch on a little bit and be able to talk in a little bit more detail today, is the RAS system. So the renin, angiotensin, aldosterone system. And again, that uses angiotensin, which is in and of itself a vasoconstrictor, as well as other mechanisms to help increase the volume of fluid and decrease the volume of that container to maintain your blood pressure in certain physiological states. So that's the arterial side of blood pressure. When you're thinking about the other side, the venous side of blood pressure, what you really have to think about is the main differences. So first of all, the biggest difference is in the function. So in the venous system, you have a really low pressure system. And there's a couple of reasons why that happens or why you would want that to happen. But really what your venous system is there for is for storage of fluid. So as fluid volume varies in different states, the venous system allows you to maintain sort of an arterial blood pressure that's consistent while accommodating extra blood fluid, or if you're getting less, allowing you to still have that good venous return. When you think about it as well, just from an anatomical standpoint, arterioles have these big, massive layers of muscle in them that allow them to contract and become smaller volume, while the venous system is quite passive. So it's essentially a container that has elasticity and valves to block backflow, but no real muscle tone. It uses basically the skeletal muscles to help push things through. So again, volume of fluid is much bigger contributor to changes in the venous pressure system. So when we think about what increases your volume of fluid physiologically, that would really be salt and water retention, which is signaled through the RAS system, which we just touched on. Okay, so there's a couple big differences between arterial and venous blood pressure, but they're affected differently into the varying degrees depending on how those factors change. So we'll jump right into the approach that I have for edema, okay? And so with edema, really what you have to think about is, what is edema? Edema is essentially extra fluid in the interstitial space. So that means that you have fluid coming out of the venous system. So remember, edema is primarily a venous problem as opposed to anything else. So this is high pressure or other factors that don't allow you to contain the pressure within the venous system and allow fluid leak out to the interstitial space. So that's really what's happening. Now, we've already learned about what the mechanisms are that cause or allow the homeostasis for interstitial fluid. And so when we think about those, we can just break those down into the 4 simple categories. So the first one is osmotic. So that's really what is the actual pressure, as we were talking about the physical hydrostatic pressure of the venous system. I see we have a question here. So hydrostatic and osmotic, yes, I would say these are the same in the way that I'm using this term right now. So really when you think about it, is if you have more pressure, more stuff there in terms of volume of fluid, then you're going to get that fluid leaking out. The other thing is the thing that holds the fluid within the vein, and that's the oncotic pressure. And so that would be mainly albumin that makes up that pressure that allows some of the fluid to be held within the veins and not to pour out into the interstitial space as much. Secondly, it's how porous are the veins, right? And so the porosity of the veins can change depending on certain states, and I have some examples there. Lastly, you will not be able to have all of the fluid that comes out. So the net fluid movement in veins or in tissues is from the veins to the interstitial space. So you need a second system to be able to get rid of that net fluid and not allow it to accumulate. So you do need the lymph system functioning in order to not have that fluid to accumulate over time. So when you think about edema, really the most important thing that you should be thinking about is, where is the edema? And so with that, where's the edema, really you can break down your differential into a couple broad categories. So you want to think about localized versus diffuse. And so the reason that you want to think about that is because it helps you differentiate and easily differentiate a couple different categories of causes. So again, we could go through these and we can say how they affect each of these factors that we just listed and how that contributes to edema. So with venous obstruction, so that again, outflow from that vein pool cannot happen as efficiently. So you get increased pressure. It's like putting a dam in a river. You get increased pressure, increased volume that stays behind that dam, and you get more osmotic pressure leading to edema in the interstitial space. You also can get cellulitis. Again, the inflammation due to the immune response usually causes more porosity in the area, which causes that swelling to happen. Lymphedema is a very specially localized type of edema, and it's usually due to downstream drainage and lymphatic drainage specifically. So when you think about what can possibly cause these obstructions, well, the blood itself can clot within the tube, but you can also have extrinsic compression. So things like masses can also cause this sort of localized edema. And then lymphedema is specifically when the lymph node system gets affected. So either with surgery, the lymph system has been removed, or it's been obstructed by some sort of external mass or pressure on it. Now, more commonly, or the thing that you'll see that has a few more causes that you need to think about is diffuse edema. So most commonly what you'll see is you'll see a dependent edema, in which the pattern of the edema will basically be dependent on gravity. So you'll see that it'll be in both legs. So that's really when we're saying localized versus diffuse, is it both sides of the body or one side of the body? And I have the first cause of diffuse edema start here because it's the most common cause of diffuse edema, and that's venous insufficiency. So when you're out in the real world, that's probably what you'll see most often. But you want to think of other systemic causes of having too much fluid on board, because again, this is a venous problem, and the venous system is particularly susceptible to too much volume, causing this edema to happen. So when you have congestive heart failure, you get the RAS system turned on inappropriately because you have low EABV, and then you get extra RAS signaling and extra fluid and salt retention, okay? CKD, you get extra volume and fluid retention because you're not able to get it out of your body. When you think about putting fluids in and out of your body, there's only a few ways we can do that, and a really efficient way to get rid and help control how you get rid of extra fluid and salt is through your kidneys. So if they're not functioning as well, that fluid's going to accumulate because you've lost one of the most efficient ways of getting rid of it. I won't go through all of these, but essentially the main principles is that you have signals that happen in each of these states that cause people to retain water. Now, in these diffuse causes, I know that in lecture you also talked about, and you will likely have to differentiate between overfill and underfill edema. And I remember this was a confusing concept for me before, but really you have to just simplify it into overfill and underfill is just asking you what's going on in the arterial side. And again, we just talked about the equivalent of having too much volume on the arterial side or too much pressure would be hypertension. So when someone is in underfill, generally speaking, the easiest clinical sign or clinical data that you can get on that to estimate how their arterial side is doing is what is their blood pressure. So if someone's hypertensive, it's likely that they have an overfill cause of their edema. And luckily, it's a pretty short list that causes overfill, so you can probably just remember this on top of your head. But mainly, it's just things that affect your kidneys. So the main things that will cause an overfill edema will be an acute kidney injury of any kind, chronic kidney disease that progresses to a certain threshold, nephrotic syndrome, again affecting the kidneys, or NSAIDs themselves affecting the kidneys, again usually causing an AKI or a chronic kidney disease. So this is the short list of them, and we'll go through some of these in more detail in a little bit and do some cases later. Now, when it comes to treating edema, there's no treatment for edema. That would be like, what is your treatment for fatigue? So you don't treat the symptom of edema, you treat the underlying cause. So when I see someone who's edematous, what I do is I diagnose them with one of these off the differential diagnosis, and I treat them how that is treated based on an evidence-based manner. So for example, congestive heart failure, a common cause of edema that you might see, you would obviously start a low sodium diet, and you would start diuretics in that instance. often you would start Lasix. Now, if you don't have a specific diagnosis, something that you can always fall back on is you can help counteract some of these factors that we talked about before. And really, it's all about pressure. So you want to have external pressure on the area that's accumulating the edema in the interstitial space. And it's usually in the lower extremities based on gravity. So compression stockings is something that often works. Now, venous insufficiency is something that doesn't have a specific treatment. So really you have to rely on compression stockings as well as that external skeletal muscle to help move the venous volume and fluid through the system. So you would not treat venous insufficiency with diuretics. The other thing I forgot to mention before we started was I'm going to ask you guys a couple questions just to keep you on your toes. So we'll use the group chat to try and answer these. So I wanted you guys to try and come up with the causes of edema that you would not treat with diuretics, and that's because they don't respond to diuretics. So I gave away the first one, but can anyone think of other causes of edema that will not be treated with diuretics? I'll give you guys a few minutes. Yeah, I think pregnancy. I saw Teresa put pregnancy. I think that's a pretty good one. You would not treat pregnancy with diuretics. I think it's probably possible, but definitely not an indication for it. So good answer. Myxedema. Yes, so any type of lymphedema. So myxedema, you've picked one of the lymphedema causes, a rather rare one. So myxedema coma caused by severe and profound hypothyroid disease, which I don't think is seen very often. DVT, yeah, that's a good answer. Great. Mass is pushing on the vasculature for sure. Awesome. It's great. Sepsis, great, good answer. Awesome. So essentially what you guys are saying is you're picking etiologies that don't have a systemic hypervolemia. So that's a great answer. So I'm seeing a lot of good answers, and I would actually agree with all of them. I know that in your lecture, the three that were mentioned for sure were venous insufficiency, malignant ascites, and lymphedema, as we've discussed previously. So again, malignant ascites, sort of cancer or these masses or stenosis that's actually blocking a specific venous return area, would not respond well to diuretics. So good job. All right, so let's move on to the next topic. So we're going to move on to hypertension. Sorry, just let my screens get caught up here. So hypertension is something that's feels like a lot of information, but I really want to try and simplify it for you guys so you just have like a good model of what hypertension is in your mind, and you know how to manage it, because it's super common. So the first thing about hypertension, the main thing is, how do you remember what hypertension is? So hypertension, the way that I remember it actually is, it's a model disease for screening. So when you think about the factors of a disease that make it appropriate for screening or ideal for screening, hypertension fits pretty well within those. So the first thing that you want to say whenever you're picking a disease to screen for is, you would say, I want to make sure that this is a disease that enough people have where it's worthwhile for me to screen for it. And I want to make sure that this disease is significant to people. So it definitely causes something that people wouldn't want to happen. So hypertension fits well with that. It's very common. Especially as you get older, the risk increases, and it causes significant morbidity and mortality. Okay. Now, the other thing that you want a disease to be that's good for screening is you don't want it to be obvious. So you want it to be asymptomatic, essentially. You want there to be some sort of asymptomatic period before you get these significant sequelae that you're trying to avoid. Otherwise, there'd be no time for intervention. Now, blood pressure also fits within that. Now, your next question is, okay, now that I'm looking for this disease, is there an easy way to find it? So blood pressure luckily fits within that as well, because it's a very simple, easily available, low skill, especially with the automated machines, procedure to try and find the evidence for this. And it's easily interpretable as a number. So that all goes well with it. The next thing that you want to say is like, do we have interventions that work? And the answer is yes. We have interventions, medications, lifestyle interventions, other interventions that decrease the risk of these bad outcomes, and they decrease them significantly. So when you're thinking about that hypertension, really it's just this perfect sort of model disease. Oops, I did not mean to click. That's okay. So what are the consequences of hypertension, and why should we care, and why should patients care? So basically what essentially happens is the vasculature starts having atherosclerotic disease and stenotic disease progressively, based on the degree and the length of hypertension that you have. So as you progress, you'll start having more manifestations of this vascular disease. And so I wrote here on the side just the different types of manifestations that you can see. And the ones on the left are much more acute presentations. That doesn't mean that they happen earlier in the disease. That just means that these are conditions that someone would present in emergency with, as opposed to these more silent diseases on the right side that progress slowly over time and may even be asymptomatic for some time. So really, when you're thinking about hypertension, we're going to focus on primary hypertension. I know that's the only topic that you've learned yet, and we'll focus on secondary hypertension later on in the course. So primary hypertension and idiopathic, we don't know why it happens, condition, which is basically a baseline. So that means long-term increase in your blood pressure. So we all have fluctuations in our blood pressure over time, but really this is an inappropriate increase of our baseline blood pressure, which correlates with end organ damage. So when you diagnose hypertension, we'll go through a case later, but when you diagnose it, and we'll go through the criteria in a second here, but when you diagnose it, people kind of get stuck. So really, I want to keep it simple. So the next one is, okay, so where are you along this disease spectrum? Are we catching you where you're asymptomatic, where you don't have complications, or are we catching where you already do have complications? And commonly you do catch people when they already have complications along this disease spectrum. So you really want to ask people, okay, do you have any other symptoms right now? And really what you're getting at is two things. You're getting at, how bad is your hypertension? Or is there something else that's bad that's causing your hypertension? And so you don't have to know those causes, but there is symptoms, of course, of the secondary causes of hypertension that might be present. And really, in the real world, that's all you ask. You just ask, are you feeling well? Are you doing your normal things? Anything new for you that you've been noticing? Now, specifically, you want to ask about these emergent conditions. And so really you want to rule out these hypertensive emergencies. So this is a bit of one of my pet peeves, which is people always say, oh, do you have blurred vision? Do you have a headache? And that doesn't make any sense to me, because people can have blurred visions and can have headaches, and it has nothing to do with their hypertension. Really what you want to do is you want to catch these emergent conditions, okay? So first of all, you're not going to catch them very often. You have to get very lucky, okay? Unless, of course, you're in the emergency department. That's where the person is presenting to. So really what you want to ask is, do you have obvious crushing chest pain, right? And then if they say yes, you will investigate that and assess that as any other chest pain. And because you want to rule out that they're having ischemia to their myocardium. You want to rule out that they're having an aortic dissection. Next, you want to ask them if they have, any obvious neurological symptoms, or if they're acting themselves. So honestly, usually you can rule these things out with just some really basic questions and doing like a basic physical exam. When I say that, I mean like appearance is everything. If someone just looks normal in front of you and they have a blood pressure of 145 over 95, you're not going to be catching anything too exciting there by, going on a 15-minute review of systems. And then again, on exam, really all you have to do is the blood pressure. That's the most important thing. So your first question should be, did I do this blood pressure properly? So I won't go through all the details, but you have to make sure that you have everyone set up well to have the blood pressure. You have to think about what you're using to take the blood pressure and in what setting you're taking the blood pressure. And then you have to think about what you do after the blood pressure. And what I mean by that is when you've taken the blood pressure, you have to think, okay, is this real? Should I take it again? Should I take it a few more times and take the average, kick out the highest one? There's a bunch of different strategies that are discussed in different guidelines, but the main thing is you have to ask yourself, how real is this blood pressure? And then really the only thing else on exam is you have to rule out these really bad things. So you have to say, okay, if this person's having myocardial infarction, do they have an S3? Do they have a displaced apex? So listen to their heart. Do they have obvious neurological dysfunction? You would obviously pick that up by just speaking with them in person. Do they have encephalopathy? Are they confused? So a really basic screening exam to pick up on these big obvious sequelae. Do they have obvious severe edema and they have CHF potentially underlying it, or CKD? So those are the things that you're looking for. And then next, what you want to do is, okay, now that I'm suspicious and I've confirmed that I've taken a proper blood pressure, what investigations may I need to do for this person who has new diagnosed blood pressure? And again, you're doing two things. You're assessing for a secondary cause of hypertension. And so you don't have to understand why we do these things, but as we just said, a cause of hypertension that we discussed was overfill edemas, so chronic kidney disease. So obviously you're going to test their kidney function and other things. Then the other side, or the other thing that we're trying to do, is we're trying to assess if there's any end organ damage and where they are along that spectrum. Because again, even some of these consequences of hypertension can be silent. So you're looking at their kidneys. Do they have CKD from their hypertension? So creatinine with the GFR. You're doing a urinalysis, okay, mainly looking for any protein. So you might formally do an albumin-creatinine ratio. Doing an ECG to see if there's any current or previous signs of myocardial infarction and ischemia. And then you also want to say, okay, even though this person may not have signs in my history, in my physical, or in my investigations, what are the chances that they do end up getting some of these vascular and organ damage? And so that's where you want to think about other vascular risk factors. So you want to do their lipids if it hasn't been done and assessed, and you want to put that in the Framingham risk score to see if they qualify for lipid lowering therapy. You want to do a hemoglobin A1C if they haven't already been screened or diagnosed with diabetes. So that's the first initial assessment. Now, the next thing that you want to move on to is, and so sorry, this is just a summary of the diagnostic criteria. So we won't go through this in too much detail, but basically, again, I don't want you to get too caught up in these numbers. Like I always just think of the numbers 140/90, and there's a spectrum. So you're gonna find patients in the real world who are kind of sitting at 160/100, and you just have to do the test to capture that. So it can be an ambulatory test, it can be home blood pressures, which is more commonly done. It can be even office setting, but you have to say to yourself, am I convinced 100% this is real hypertension versus something else like white coat hypertension? And you're at higher risk of doing that if you're only measuring in the office. So that's why there's these preferences for having automated blood pressures done, having out of office blood pressures done, because those matter more, because we care about if someone has high blood pressure baseline every single day of their life when they're out in the normal world living their life. Okay, so know these, if it's super obvious how high their blood pressure is, boom, it only takes one visit, they have hypertension. If they have diabetes, that lowers our threshold even further because we have a lower target and they're at higher risk for the ththings we're trying to avoid. Okay, so I want this to make sense to you. You don't have to memorize these numbers. Like in my day-to-day life, I remember 140/90, and everything's pretty close to that. So that's reasonable to have in your mind. Maybe right before the test, it's good to just take a look at these numbers. So on the next slide here, we're going to talk about therapy. So again, what's our goal of therapy? So everyone talks about blood pressure goals, and to me, that's not our goal. Our goal is to reduce the risk of end organ damage. And lots of times we can say, okay, we can use evidence to tell us in general, based on this person, what kind of target should we have. And this is up for debate because it's obviously a spectrum. In general, the evidence, if you want to summarize it, says that the lower the blood pressure, the better off, or the more you've reduced that risk. Now, you also want to balance this with avoiding harmful side effects. And these are real side effects. These are side effects such as, falling, breaking your hip, and even death. So when people say, lower the better, and that's the full conversation of kind of treatment with antihypertensives, I would argue that really what we want to do is we want to say, okay, what's the risk of this person getting end organ damage? So what's their other comorbidities? What's the chances of them getting this damage while they're still alive? So what's their life expectancy? And then what's their risk of having harmful side effects? If someone is quite frail, has poor balance, has fallen before, I'm obviously not going to be as aggressive with blood pressure therapy. So that's sort of my goal with blood pressure therapy. So 140/90 is helpful to help guide you, but it's just a starting point with that conversation with the patient. So really what you have to do is you have to educate this patient. They have hypertension for the rest of their lives. This isn't really going away anytime soon. So you have to work together to allow them to understand what their condition is and how they're going to control it and why they need to control it. So you need to tell them what I just told you on that previous 2 slides. Now, when it comes to treatment, you want to start with conservative therapy most often, especially if things are mild. So if their blood pressure numbers themselves are just mildly elevated, so less than 160/100, and they're low risk, then you can start with conservative therapies. And the big 4 that everyone should be told when they're diagnosed is alcohol cessation, that can have a big effect on blood pressure, weight loss, increasing your activity, and then also changing your diet. So there's many different forms. The simplest is just reducing your salt intake, which doesn't have as much of an effect as actually changing your diet in general and the components of it. So the DASH diet is the most popular one. This isn't the be all and end all. So other things can also increase your blood pressure, but they usually don't have as big of a contribution. Smoking definitely deserves some focus, because not only could that be contributing to your higher blood pressure, it doesn't have a huge effect on blood pressure, but it definitely has a huge effect on the same thing that we're trying to do, which is to reduce the risk of end organ damage. So a huge risk factor for vascular disease is smoking. So you want to cover that as well, but as a technical answer for lowering blood pressure, not as effective as those other 4. Next, what we do is, next what we have here is we're just going to chat about pharmacotherapy a little bit. And so when it comes to pharmacotherapy, the first thing that I would say is that you want to be the turtle, not the hare in this sense. So I'm going to go back to the concept of hypertensive emergency and hypertensive urgency. So first of all, hypertensive urgency is a nonsensical term that should probably never be used. It's just arbitrary. It doesn't help us make any decisions whatsoever. But hypertensive emergency is helpful. And really what that is, it's a presentation with someone who has hypertension and one of the emergent complications of it, meaning myocardial infarction, stroke, aortic dissection. So when these people present, it's pretty obvious. You're not like, oh, their blood pressure is a little high and maybe they're having an MI. You're like, they're having an MI and their blood pressure is super high. So what you should be thinking about is, how do I treat blood pressure in the setting of an MI? Not how do I treat blood pressure in the setting of someone who has this non-specific chest pain, right? So really the most important thing is making the diagnosis of an emergent hypertension by making a diagnosis in addition to just high blood pressure. So we've found through evidence that lowering someone's blood pressure, no matter how high it is, if they're not having an emergent complication from it, is not helpful. The most helpful thing is actually resting, telling them to go into a quiet, dark room. So you want to go slow and steady here, and that's because you want to avoid their harmful side effects. So when it comes to pharmacotherapy, there's those 4 big categories, and we're going to go through those in more detail on a graph on the next slide. Don't forget that even if you're kind of at your wit's end and people are doing everything they can conservatively, there on maximum pharmacotherapy, there is still some other options in renal denervation. And then for specific etiologies as well, there's some invasive therapies. So just don't forget that in mind. This is the same framework that I always use. So, you know, you want to educate the patient, you want to make a goal together for what the therapy is, and then you want to think about conservative options, pharmacotherapy, and more invasive options. Now, for follow-up with this patient, whenever you start something that can affect the kidneys, so a diuretic, an ACE or an ARB, you want to check their creatinine lights 2 weeks after starting that medication. And the reason is that's when they approximately reach steady state. So if they get a hyponatremia, if they get a hypokalemia, or whatever it is the side effect from that medication might be, you'll see it after 2 weeks. And then of course you want to monitor the blood pressure response. And I think when it comes to monitoring blood pressure response, like there's no real guidelines around it. And that just goes to show that making the diagnosis is probably the hardest part, but really what you just want to, the essence of it is you just want to figure out what is this person's blood pressure, or what's the best way to guess or accurately get this person's blood pressure measured in terms of what it is every single day when they're living their normal lives. So often what you do is I see some questions about these numbers and we'll go through them in a second, sorry guys, but often what you do is you just have them measure at home with their own cuff. And then of course you monitor for specific side effects, which we'll go through in the next slide. So I see some questions here. So basically what this means is that you get a 2 millimeters per mercury drop for every kilogram of weight lost. So that means that you have to lose quite a bit of weight to have a profound effect on hypertension. Same with activity. So the average sort of difference in people who increase their activity is 6/3. And so the main thing with conservative things that I want to bring your attention to is they're pretty modest effects. You can make a difference, but unless someone is obviously, you know, drinking 20 alcoholic equivalents a day, you know, BMI over 40, like these extreme cases, there definitely can be a huge effect. But overall, the majority of people that you're going to see, the conservative therapy just won't be enough to make an effect. So that's really why you want to go with the low risk people and the people who are just barely meeting criteria for hypertension. And yes, and so the top number is systolic and the bottom number is diastolic. These numbers are not important. The important thing is that the numbers are not as high as what you get from medications. So often you do need to rely on medications, especially if their blood pressure is greater than 160/100, and especially if they have risk factors and you want to make sure that you have really good control. Okay, I hope that answered your guys' question, but feel free to put that in the chat if not. Okay, so I made this table for you guys, and I won't go through it into too much detail. I just want to talk about the general trends. So let's use ACEs and ARBs as an example. So first of all, ACEs and ARBs. So you guys kind of are familiar with these medications. So something I want you to keep in mind is, again, look at the mechanism of action of all of these medications. The majority and the major mechanism of action that you'll see is vasodilation. Obviously, you lose a little bit of fluids, particularly with the diuretics. But what you want to do is you want to make that container bigger, because that's the most important thing when it comes to arterial blood pressure. So a couple things to keep in mind is that not only are these medications used for hypertension, they're used for other things. So when it comes to picking a blood pressure medication, I personally always start with an ACE inhibitor and an ARB. And that's because it has so much protective effect of cardiovascular complications that even if you can't find someone who has cardiovascular disease objectively, if they're at moderate or high risk for it, I'm going to want to make sure, or if they have it hidden and I can't find it on tests, but the disease is there, I'm going to want to use ACEs and ARBs. The second reason why I always use ACEs and ARBs first is because they're very easily titratable. What that means is as you increase the dose of an ACE or an ARB, you get a proportionate increasing response. That is not the same with other antihypertensive medications. Unfortunately, once you get to a therapeutic dose with these other medications, going higher does not have much more of an antihypertensive effect. So ACE and ARBs, really, really good. In terms of side effects, the main ones that you need to know is they can obviously cause acute kidney injuries. The most common reason for that is because of already impaired blood flow due to renal artery stenosis. That's another cause of secondary hypertension that you'll learn in more detail later. And then the second side effect is the ACE inhibitor cough. You definitely want to remember that, sorry. Next is diuretics. And on the next slide, we'll actually go through diuretics and their mechanism of action a little bit more. But the main thing that you'll see with diuretics is these electrolyte abnormalities. And really the biggest one, the one in the real world that we see so often, is thiazide-like diuretics causing hyponatremia. So definitely keep that one in mind. That's definitely something that can show up. So thiazide diuretics, commonly referred to as the first-line management. These are all technically, all the options on this page are technically first line. I don't use hydrochlorothiazide. It has been not proven, or what I should say is it's been proven to have no effect on mortality benefit, but other thiazide-like diuretics like chlorthalidone and dapamide have. So you should always choose those. But there's a super high risk for hyponatremia, and hyponatremia is a big deal. Like, I see these in the hospital all the time. There's these old frail ladies who are falling over, like overtly confused, breaking their hips because of hyponatremia, and they got started on a hydrochlorothiazide medication 1 or 2 weeks earlier. So you definitely want to try to avoid these medications in someone who seems frail or brittle, I guess is another word that some people might use. But you definitely want to try to avoid these. Now, the other diuretics aren't often used in hypertension unless it's refractory. Spironolactone is often used in refractory hypertension, or you have some of these other indications. So think about diuretics, again, we use them more in edema in hypervolemic states. So that's why CHF, chronic kidney disease, cirrhosis is within this, okay? So you don't have to know all these details, but just know these general trends. The other thing that I'll add lastly is just that I put non-dihydropyridine calcium channel blockers with beta blockers because essentially they do the same thing. They have the same effect in that they decrease heart rate and cardiac contractility, as well as having that vasodilation effect. So again, this is technically a first-line treatment, but I wouldn't use it first line. People who are older will get severe fatigue and side effects from this medication, potentially cause bradycardia or a heart block if they have some sort of other underlying cardiac disease. And younger patients, you'll put them on these medications and they'll say, hey, why can't I work out anymore? Why am I so tired all the time? They can't live their sort of young, exuberant life, it seems. And so they hate being on these medications. The other thing to keep in mind, just to reinforce a concept before, is that it really is the vasodilatory effects of these medications that have the effect on blood pressure. And with beta blockers, it's a bit of a misnomer because they're not pure beta. They also have an alpha effect. And really it's the beta blockers that have more of an alpha effect because that has more of an effect of vasodilation that are effective in treating with blood pressure. Ones that have more of a heart rate effect and a cardiac contractility effect don't affect blood pressure that much and are not very good antihypertensives. So again, one other thing to highlight here is expect a blood pressure drop of approximately 10 in systolic and 5 in diastolic per medication. And some of them can have some synergistic effect, but mostly what you're doing is you're just adding these on top to each other. So you're just gonna max out one medication. So I always max out my ACE and ARB because I know I'm gonna get additional effect as I keep going up. And then I start maxing out these other things. These other things, I don't go max dose. I just go to therapeutic dose because as you go higher in doses, as you get more combinations of medications, you're more likely to get side effects. Okay, I think that's all the really big things on this slide. So next, what we're gonna do is we're just gonna go through diuretics and the effect and where they have an effect on the kidney. So I think that's an important concept to understand, especially as you start doing more nephrology in future lectures and weeks of this course. So I see a couple questions, sorry, before I move on. What drug would you suggest for a pregnant patient? So there's 2 drugs that are commonly used in pregnant patients. and they're not traditionally used in any other situation. These drugs are used because they've been studied, so they know that they're safe. So the first one is nifedipine, the calcium channel blocker. So this is a dihydropyridine, so it only has a vasodilatory effect. Amlodipine is the other common one that we'll use outside of pregnancy, and they're in the same drug class. Or labetalol, which again is a beta blocker. It's often not used because of those things that I just said. You know, it has lots of side effects. People don't really like it, but it is a safe and reasonable option also first line. So nifedipine is the one that you'll see most often. Okay. Diuretics. So really there's 4 main sections of the nephron, and we'll kind of go through what they do and how the diuretic has an effect on them. So when we have a diuretic, so I just saw this one question pop up. Okay, so when it comes to pregnant patients, just to jump on that one more time quick, is this for patients hoping to get pregnant and or patients with preeclampsia? So the reason that the other medications are avoided is because they're not proven to be safe. Even some of them like ACE inhibitors and ARBs are proven to be teratogenic and harmful to the fetus in pregnancy. So when someone is a middle-aged female who could potentially get pregnant, I would avoid ACEs and ARBs, and I would start them on something that's safe like nifedipine. Okay, so lastly, so the nephron. So the first part of the nephron, the proximal convoluted tubule. So when it comes to the nephron and the diuretics, so when you think about this, diuretics were designed by us to have a potent effect. So they're gonna affect the most important channels in each part of the nephron. So that's why you can kind of go through it together. So the proximal convoluted tubule is the powerhouse of the cell, or of the nephron, I should say. And what it does is it absorbs all of the valuable things back. So obviously we're gonna inappropriately, or not inappropriately, but we're gonna accidentally filter some things through the glomerulus that we want back just based on their size, because really it's just a pressure system, high pressure system with pores to push out the solute within the fluid. And those things are like proteins, signaling molecules, sugars, and glucose. Bicarb is obviously very important. If you're wasting your bicarb, you're gonna get acidotic. So this is a really important part of the nephron, and it works super hard to get back these important things. It uses up a lot of energy. Because of that, it's susceptible to ischemic injury and it's susceptible to toxins. Now, in terms of the diuretic that has an effect on this part of the nephron is carbonic anhydrase. It's not a very potent diuretic, so it's not used for blood pressure or edema management. It's used for other things. So you don't really have to know much more about it. It works by inhibiting bicarbonate to be broken down and reabsorbed through the cells. So you'll be wasting bicarb with that diuretic. Next is the loop of Henle. So as you go down the loop of Henle, remember you're only losing water, and water gets pulled up because you have this nice salty medulla. So you're going down into the medulla of the kidney and you're losing water down here. So now you're super concentrated. So now you have a concentrated filtrate within the nephron. And as it comes up the ascending loop of Henle, you have more transporters here that are getting that salt out. And really what that is doing is creating a salty medulla. So this is, again, the engine that powers the loop of Henle. And so what a loop diuretic does is it blocks one of the main transporters here. And when it blocks it, what it does is it doesn't allow that salty medulla to happen. So you get interstitial washout, which means this engine is not putting salt into the medulla, so you're not getting water pulled out on the descending part of the loop. And you're also not getting water pulled out later on when the collecting tube dives down deep into that medulla where it used to be salty. And we'll get to that in a second. So the loop diuretics have quite a strong effect because this is a part of the cell that causes you, or of the nephron, I should say, sorry, that causes you to make that salty medulla and allows you to get those electrolytes back. Now, when you don't have the salty medulla, then what happens as you get down over here? And we'll get there in a second, but I want you to think about that. So the next part, just going in order, is the distal convoluted tubule. So you have your thiazide diuretics here, and essentially what they will do is they will block this sodium chloride transporter. And what this really does, what you want to think about the distal convoluted tubule is sort of like the fine tuner here. So it doesn't do a lot of the work, but what it does is it fine tunes the solute concentration when the filtrate within the nephron. And the reason that that's important is because you have a macula densa and the juxtaglomerular apparatus, which is basically just like this fancy sensing system, which tells you how much flow you have in the distal nephron. So flow would correspond to how much pressure and how much blood is getting here, which corresponds to how much volume I have. So that macula densa and juxtaglomerular apparatus is what actually signals the RAS system to turn on. So this distal convoluted tubule will have a large effect on the RAS system, as well as the loop diuretic, because you'll get less reabsorption of electrolytes and water, and you'll get more distal nephron flow. So that distal nephron flow, when you're using a thiazide diuretic and a loop diuretic, causes your RAS system to turn on. So why is that important? So your RAS system turns on. RAS is renin, angiotensin, aldosterone. So aldosterone is going to cause you to kick back more sodium into your body and kick out potassium. So you get hypokalemia, which is a side effect of both of these diuretics. The other thing you'll get is hyponatremia. And the reason that happens is because not in the name of RAS, but also signaled by RAS is antidiuretic hormone, ADH. And so when you have ADH turned on, what you get in the collecting tube here is you get more ADH in the cell wall, more absorption of water back into the interstitium, back into the body, and you get more water, you dilute your blood, and you get hyponatremia, okay? And we'll go through that again in a second here, because we still have to go through the collecting tubule. So the collecting tubule is basically our last ditch effort to do a couple or a few things in the nephron. So when you think about big jobs of the nephron, there's a couple things. One, you want to have volume control. So you want to be able to control water going in and out. Two, you want to be able to control how much salt you're reabsorbing. So sodium mainly, because it's the most prevalent salt in your body. So you want to be able to reabsorb some salt and water if you need to in the collecting tube, I should say, right at the end. And lastly, the nephron likes to kick out potassium. It's toxic when it accumulates. So a big job of the kidney is to get rid of potassium. So the collecting tube gives us the last ditch effort to fine tune sodium, to fine tune water and not get dehydrated, and to fine tune potassium to kick out some extra and not get the toxic accumulation of it. So how it does that is through these cells here. And so these cells, basically what happens is if you get increased flow and the RAS system is on, then you have ADH, you have aldosterone, which is putting in this sodium transporter, and you have potassium that's coming out in exchange for that sodium. Sorry, I said that the opposite way. You have sodium going out of the nephron, which has been put in there by aldosterone, and then you have potassium getting kicked out of the body, peed out in exchange for that sodium, and then you have ADH pulling water out. So increased flow with these two diuretics, you have the body saying, okay, turn on RAS so that we can turn on aldosterone, get more sodium, water follows it, and we can get ADH to put more aqueous porons in there to get more water out of there, and then we'll sacrifice some potassium. So that's why you get those side effects. You get a ton of water, and you also get a ton of salt, and you kick out some potassium, you get hypokalemia. Water will come out preferentially to sodium only when there's a really salty medulla here. So this is the reason why loop diuretics often don't cause hyponatremia. So I see one question coming and I'll get to it in a second. So when you have a loop diuretic, you're getting distal flow, which turns on your RAS system, right? Because you're not absorbing this. So your RAS system is turned on, ADH is turned on, and water, or what I should say is aquaporons, are in this collecting tube. But really the thing that drives water coming through those aquaporons from the nephron to the interstitium is the salty interstitium. And we've just turned off the engine with the loop diuretics. So often with loop diuretics, you don't get hyponatremia. You can, but you often don't. What you do see is lots and lots and lots of hypokalemia, because you're kicking out tons of potassium and this aldosterone system is still working completely fine. So with thiazide diuretics, the loop of Henle is working fine. You still have a really salty interstitium, but you still turn on your RAS system because you have increased distal flow sensed by the macula densa. And then you get the RAS system turned on, you get these aquaporons, you still have the salty medulla, you pull in a ton of water, right? And that water overwhelms your system and causes severe hyponatremia. So that's why there's that difference between loop and thiazide diuretics. Even though they both turn on the RAS system, the loop diuretic also poisons the kidney in terms of not allowing it to create a salty medulla. Now, there's one last diuretic that can take effect in the collecting tube here. And what that diuretic does is it blocks aldosterone. So it blocks sodium from being reabsorbed, right? So you're losing more of it. And it blocks potassium from being kicked out. So you keep more of it. So the side effects of that diuretic would be hyperkalemia, which is distinct from the hypokalemia that you can see both in thiazide and loop diuretics. So that's the reason you see these different electrolyte abnormalities. It's all physiology. That was a lot, okay? I'm not sure if I confuse you guys more, so hopefully any questions that come up, you guys can put in the chat. I know that we're kind of running late on time. All I have left after this is some cases. So you guys, if you guys have to run, no worries. We'll keep recording as well as we go through the cases. The only question I see is the goal of RAS to increase blood pressure? Yes, right? So the goal of RAS is to increase blood pressure. So the assumption that your body makes is that if your kidneys are not seeing, if your kidneys are not seeing enough flow or blood pressure, then they want to hold on to salt and fluid to allow that to try and compensate for it. So the goal of RAS is to really, it's kind of I would say it's what's the word I'm looking for? It's not a specific precise thing. So it's one of many compensatory mechanisms that your body can do to avoid hypotension, because hypotension kills us really quick. So it's how can we hold on to fluid? So yes, one of the effects that it tries to do is increase blood pressure. And sometimes it does that appropriately, sometimes it does that inappropriately. So yes, so you're correct. So when the glomerular apparatus is seeing increased flow, what it thinks is that it needs to try and reabsorb that water early on. So something that the RAS system also does is it increases the proximal tubules metabolic rate. So it increases how much is absorbed in the proximal tubule. So when you have increased distal flow, what it's basically saying is something is not working in the proximal kidney, and we need to ramp up the activity in the proximal kidney to help reabsorb that salt and water. Otherwise, we're going to waste it all, because the collecting tube, again, it's our last ditch effort. The powerhouse where the majority of reabsorption happens in terms of volume of fluid is in the proximal tubule and in the loop of Henle. So the RAS system is saying, okay, we're wasting way too much salt and water in the distal nephron. We need to turn on the proximal nephron. We need to release angiotensin to clamp down our blood vessels. We need to release aldosterone to get more salt in the collecting tube. We need to release more ADH to put aquaporons in the collecting tube to reabsorb more water. So you're right. So it's a bit counterintuitive where you would think increased flow means that the kidney senses that there's something wrong that needs to actually maintain or reabsorb more water and salt. But what you have to think about is from the perspective of the kidney is that means that if it's sensing it very late in the nephron, that they're losing a lot of water and salt, and what they'll do to compensate is try and hold on to that, because it's a much greater risk to become hypovolemic, hypotensive, and die quickly from that. Okay. I hope that makes sense. So let's move on to cases. So again, if people have to run, and no worries, I totally understand. I know we've gone a little bit long. So this first case is going to be about edema. So I want you guys just to take a few minutes to brainstorm, like, what would be the big HPI questions that would help you differentiate some of those etiologies we talked about before? What would be like the previous medical history questions that would be like need to know that would help you differentiate and reorganize that differential? What physical exam maneuvers would you want to do? And what are the investigations that you'd want to do for edema? So I'll give you all like 3 or 4 minutes to kind of go through that, and then I'll tell you what my answers were as well, and we can just kind of talk through about why it's helpful and why we think of those. And yeah, and feel free to put these in the chat as well, and we'll just kind of brainstorm together, and once we get a good list, maybe we'll just move on to the things that I had written down. So I see bilateral leg edema. That's excellent first question. Definitely should be your first question, as we talked about before. So good job, Natalie. I'll give you guys a few more minutes. All right, some great answers so far. So, Cavi, I'll just challenge you. What CHF symptoms would you ask about? Yes, very good. Okay, awesome. I think we got a pretty good list there, and I hope some of you guys are making your lists at home, but let's just go through some of these. So HPI questions. So this is already been excluded based on the stem, but arm, right? So what if it's not your legs? So a really common thing that you'll see is actually surgery or post-surgical lymph node dissection due to breast cancer causing arm lymphedema, super common. So expect that as a big clue if you see that. DVTs can also happen in the arm, but very, very rare. Unilateral, right? Is it unilateral or bilateral? Perfect. So if you see or they're complaining about legs, that should be your first question. Again, the unilateral thing is a very short list. DVT, right? And we can talk about the risk factors for that in a bit. Cellulitis, right? Is it a mass? It's a very short list, right? And these will be all quite easily differentiatable from each other. Is it diffuse, right? Like just looking at the person, do they have swelling in their hair, like around their eyes? Are they complaining it in their genitals, like in their scrotum? You know, that's pretty severe edema and would definitely raise the possibility that this is a severe systemic problem like nephrotic syndrome. Fever, for sure. So these are getting to the associated symptoms. Definitely shortness of breath, right? And even better to say is orthopnea and PND, right? I get short of breath all the time, but it's not orthopnic or PND, so I should be fine, I think. weight gain or abdominal distension, right? So if it's more of a systemic issue, if it's more in the abdomen, they're loosening their belt, right? Think of things that are not just specific to vasculature, but higher up, right? So that causes that that backflow from the heart, or the backflow from the water wicking off the capsule of the liver, right? And then what if it's none of these? So venous insufficiency. So venous insufficiency sometimes is a bit nebulous, but really it's like, if you just can't figure out quite what it is, again, think venous insufficiency. It's like, oh, there's not much going on here other than you got some swelling, you know, in their older age. Definitely think about that. These are pretty simple. We kind of already went through some of these, but definitely you want to ask about heart, liver, kidney, right? Whenever I see someone who has edema, I always ask them, do you have any heart issues? I listen to their heart. Do you have any liver issues? Do a basic liver exam. Do you have any kidney issues? You know, there's not a great kidney exam, but there's a really easy test to see their kidney function. And then medication. So there's a couple big ones that were mentioned in your lecture slides. So the dihydropyridine calcium channel blockers, so amlodipine, this is probably the most common one I see in real life. And then the two that were listed in your lecture were NSAIDs, as we talked about before, and I'm not even gonna try to say it, but it's a old diabetic medication, which was found to often cause CHF exacerbations, and obviously worsens edema. All right, what about physical exam maneuvers? So abnormal vitals and very sick. So think about sepsis, right? Like there's different settings where you can see edema, and definitely in critically ill and severely ill people, you can see it for sure. The appearance of it, as I said before, just general, JVP, so the signs of CHF, stigmata of chronic liver disease. And then cellulitis, you know, if they have this really well demarcated, tender, warm skin. So really think about those cardinal features of infection, right? You've loss of function, swelling, redness, pain, warmth, right? Think of those 5. And if they have a few of those, you definitely got to think about infection. Varicose veins is such an interesting one. Venous insufficiency, you'll definitely see varicose veins. Really, essentially what venous insufficiency is basically those valves have stopped working, and that causes backwards flow and increased pressure in the venous system and edema. But also you want to think about DVT if you only see the varicose veins. Again, you want to go back to that first question, is it unilateral or bilateral? And then non-pitting. I don't think you'll see non-pitting edema very often, but lymphedema is definitely possible. The most classic example is the lymph node dissection. Okay, investigations. So does anyone want to say what investigations you might do so in the chat, why don't we just have some people put some ideas of what investigations might be helpful in someone who has edema. So as you guys think about that, all I'll say is I put none here because often that's what you do, none. And that would be the pretty typical patient. You kind of go through all of this. They have a pretty normal physical exam. They have no cardiac, no liver, no kidney issues. They're otherwise healthy. They're not on any medication. They're just complaining about this sort of like non-specific worsening bilateral pedal edema. Gets worse throughout the day, and it's kind of been slowly progressive over time. So if it's not one of those people, they have some of these things on physical exam, they have some of these risk factors on their history. All right, so again, keep it simple. So kidney function, liver function, super easy blood test to do. A urinalysis, right, to look for any protein, like in a nephrotic syndrome, which you'll learn about later. Look for protein from a chronic kidney disease. And then also looking at the heart with an ECG and echo, looking for evidence of either previous or current ischemic changes. All right. All right, so the next one case that we're going to do here is one on hypertension. So you have a 47-year-old male in your family medicine office for a refill of Viagra. And this is often what happens. The nurse has recorded a blood pressure of 155/93. So oftentimes that's what happens is people kind of come in and they basically incidentally get found to be hypertensive. So what would be some questions that you would have going into the room with this patient? I'll get you guys just to pop them up on the chat there. I'll give you a couple minutes. So what would be some things that you would be thinking? Yeah, great question, Phoebe. How's he feeling, right? Do you have any symptoms? Kind of looks at you surprised. He's like, no, why are you asking, doc, right? That's a pretty good sign, actually. Yeah, that's amazing. Yeah, great question, right? You want to make sure this is real, right? So it's like, what was he doing before? Is he running in here up the stairs late for his appointment? Does he smell like smoke? Is he a smoker? Did he just have a smoke? Was his feet flat on the ground? Was the nurse in here talking with them? Were you in there talking with them while it was going on? What about, have you ever measured your blood pressure before? Yes, it's as close to your reading. Are you surprised by this? Great question. Okay, so that's a pretty good start, I think, right? And then if you're unsure, repeat it, right? Repeat that blood pressure. Super helpful, right? So you ask that question, he does measure his blood pressure at home. Let's say he has about 20 measurements done over the past 3 months, and the average is 149/87. So what would you guys say about that? If he's got a pretty persistent few-month history, measuring at home in a reasonably accurate way, what would you say about that blood pressure? Oop. Yeah, so exactly. So you're making the diagnosis here, right? So what would be the first step once you've made the diagnosis? So what might happen in real life is you say to this guy, hey, your blood pressure is a little bit high, and I think you might have hypertension, right? Well, he's probably heard that term before, but he probably doesn't understand the consequences of that the same way that you do. So you guys are getting to the right stage. You have to assess for cardiovascular risk, but the first thing is educating this patient, making them understand what the diagnosis is that they just got and why it is that we care about it, right? So this is a progressive chronic disease that increases your cardiovascular risk. And then boom, that reminds you, yes, we have to think about cardiovascular risk. So you would ask this guy, hey, are you on any other medications? Do you have heart issues in the past? Have you had a stroke in the past? Are you a smoker? Have you ever been tested for diabetes? You know, is this person obese, right? Do you have a family history of cardiovascular disease? You want to assess for all those risk factors. Okay, so this guy's kind of scared now. You know, you told him he has a condition that could shorten his life. It's going to last for the rest of his life. He's saying, geez, what can we do about this thing, right? So again, hierarchical. So this guy has a blood pressure of 149/87. So if when you said lifestyle mods, that's great. That's the perfect answer, right? So this guy's borderline hypertension. Now, if this guy was 85 years old and his chief complaint was dizziness, am I going to be like, oh, actually, the more important thing for today's visit is your borderline blood pressure, and I'd hope to give you a medication to maybe make that dizziness worse? No, you're not going to do that, right? So context is everything in this sense. So this guy's otherwise healthy guy. He's not on any other meds that he takes regularly. He takes Viagra kind of on an as needed basis. So you're not going to start talking about a medication for this guy right away for a few different reasons. The first reason is because the degree of which his blood pressure increasing. So he's still pretty young, doesn't have any other conditions too, so he's low risk as well. So he fits that criteria we made before of less than 160/100 in terms of blood pressure reading, as well as being low risk. You can definitely start with the lifestyle mods. So what lifestyle mods would you suggest for this gentleman? And you guys can just put it in the group chat there, or you can low sodium diet. Yeah, not a bad start. So you talk about diet, right? Do you eat out a lot? What kind of things do you eat? We have a dietitian in our clinic who probably can speak to it more than me, right? So you can ask him, do you want to talk to a dietitian? Hey, have you ever heard of the DASH diet? Do you want to look it up? Chat about it next week. Exercise, great, right? Where's your exercise at now? Smoking cessation, right? Especially from a cardiovascular risk standpoint. Perfect. 150 minutes per week, right? That's the recommended amount for exercise right now. Wow, random question was exactly what I was hoping to hear. So Natalie has said, are we concerned about this initial reason that he's coming in? So erectile dysfunction is often the most common reason that it happens is due to peripheral vascular disease. So when you see this guy, that should be a little bit of a flag. Like, even if I do all my initial investigations like I'm supposed to do and I don't find anything, I'm going to pay pretty close attention to this guy going forward. I'm going to ask him maybe a little bit more detailed questions. You know, this is a guy where you for sure want to ask, hey, in your family history, any of the guys or women die younger from heart disease or have heart disease at a young age, right? You're really going to search for a reason that this guy's risk might be higher because you have a clue that his erectile dysfunction might be something to do with this hypertension that you just found. So that's a really good point, Natalie. So that goes into the complexity of these cases. Awesome. So that brings us to our next point, right? Not only are we going to focus on his blood pressure and focus on some of these conservative interventions, but we're also going to say, okay, what investigations do we need to do to make sure we're not missing and we're just unaware of some of these risk factors, right? So remember before we talked about the different investigations that you would want to do. And one of them is to look for secondary causes of his hypertension, which you're not too suspicious of because he has no symptoms, very mild. And so you would do that. And then you would also look for other things that can increase his risk. So diabetes, you want to do that hemoglobin A1C. How are his lipids and cholesterol doing? You want to do that lipids and Framingham risk score. Does he have chronic kidney disease, right? All of these things, that's great. Yes, there is a relationship between erectile dysfunction and atherosclerosis. That's right. So it's quite well established. So I don't know many of the details of it off by hand, but it definitely should be a clue to you whenever a middle-aged or older male starts complaining of erectile dysfunction that they could have underlying vascular disease. Okay, so let's say we do all this by the books, and then we say to this guy, okay, we think you should do all this. He goes, you know what, like I'm already doing some of that stuff. The other stuff doesn't sound too interesting to me. Don't you think we should just take a pill, doc? I'd much prefer that. And you'll get patients that say that. So you say, sure, why not? So he agrees to start perindopril 2 milligrams once daily. So what would be your follow-up for this patient now that you started this medication? Yeah, not a bad. And what would you have him do in the meantime? Perfect, right? You're starting a medication, so you have to go through, okay, this medication works through this way. It's supposed to have this effect. It's going to lower your blood pressure. So we're going to measure the effect that it has on that. We don't want some of the other effects of this medication to happen. So we're going to try to make sure that these don't happen. We're going to monitor for them. And you talk about dizziness for sure. What are some other complications or side effects, I should say, of perindopril? Cough, for sure. So when he comes back in a month, you're going to ask him specifically about cough, for sure. Yes, right? So we're really worried about the electrolytes, hyperkalemia primarily with an ACE inhibitor or an ARB, and worsening renal function, okay? So this guy, you want to have that blood work done in 2 weeks because he's going to reach about a steady state from a renal function and electrolyte standpoint in about 2 to 3 weeks after starting it. So you're going to give him a rec. You're going to say, take this in 2 weeks. You start getting really, really dizzy. You're going to call me early and you're going to stop your medication. Or if you start getting a cough, you're going to stop your medication and call me early. Otherwise, everything goes smooth. Blood work in 2 weeks. Measure every second day what your blood pressure is. Here's the proper technique to do it. I'll see you in a month, right? And you're done. Okay, so we went through that case. that's the end of the slide here. So we can go to some question and answer. So feel free to chat if you guys like. I know I've gone long, so I don't expect you guys to stick around, but I'm happy to answer any questions about stuff that we specifically went over that we maybe just touched on and you had some questions about in general. Yeah, so Nelly, so I see your question. So really what you're wanting to do is you're wanting to see how concerned you are that there's another etiology other than venous insufficiency. And, you know, people, when they come to you with edema, are usually annoyed by it. And they're annoyed by it for a couple different reasons. One, it's just like the physical effect of it, the way it looks, the way it feels, you know, putting on your shoes, etc. And then the other reason is that it hurts, right? So they usually come and specifically wanting you to address that. So if you do open up the conversation a little bit bigger and start saying, you know, there's other things that this could be a sign of that we want to check into if you're worried about them, it's really based on that history and physical. So patients aren't typically looking for investigations, and often patients don't have concerning histories, and we're able to not do any investigations and basically talk about the conservative things like, you know, reducing salt intake, staying fit, doing exercise, and then also using the compression stockings as well. Really, as people get older, as they have more comorbidities, you start worrying about cardiac, liver, kidney concerns. And so you may do some blood work or may do some investigations of the heart with like an echo or ECG. But oftentimes people either have an underlying diagnosis that explains their edema, or their edema is not concerning, and they don't have any other symptoms, and you can essentially monitor it and follow it along. Do you know why alcohol is bad for hypertension? Yes. So you guys have experienced a hangover, right? So when you are hungover, so a good objective way to look at what a hangover is to look at the, why is the name slipping my mind, for the CWA. So you look at CWA scores right in there, blood pressure is in there, right? So the more someone drinks and the more that they have the metabolites of alcohol in them, the more that those effects will happen. So it's the metabolites of alcohol. And that's why if you don't drink every day, you'll notice that when you're hungover the next day, your blood pressure is up. And then people who are constantly drinking constantly have those metabolites at high levels in their body, which allows that, causes that hypertension cause. I don't know the specific, you know, mechanism, but alcohol can cause that hypertension. It's very well described. I hope that answers your question well. Okay, so if there's any more questions, I'm happy to answer them. Let's just
had one.
Yeah, so
if you are okay, I'm really still confused about the like what is being detected to turn on the RAS system and ADH within the macula densa and the juxtaglomerular apparatus. So like I'm just a little bit confused because we are thinking, okay, so RAS should turn on to increase blood pressure. So this should tell us that if blood pressure is low, that means kidney perfusion is down, which means the pressure in the arterioles should be down, right? And if we are giving the loop diuretics, then we're stopping that medulla from becoming salty, which means urine osmolality should go up because there's an increased sodium concentration in the urine or in the filtrate at that point. So from my understanding, macula detects the urine concentration and juxta detects the pressure of one of the arterioles. I can't remember which one, I'm a little bit confused about that increase in flow. Like, how does that work?
Yeah, it's a great question, Anna. Um, so when it comes to the sensing, you know, I don't get too bogged down in the details for better or for worse, but the main thing is that, you know, the RAS system will respond to two things. It'll respond to increased distal flow, and that can be, you know, the higher your concentration is with salt, the more water that will be following it as well. So in general, you can kind of look at those as equivalent things. So if you have a higher salt concentration, actually in terms of just overall flow and pressure in the nephron, you'll probably have increased flow as well. Now, what happens with a loop diuretic? You're totally when you bring up urine osmolality, that's a good concept to think about, because with the loop diuretic, let me just go back to the so with the loop diuretic, when you block out the loop of Henle and you don't get the salty medulla, what you get over here actually is the ADH is on and the aquaporin's on, but you're not having the salty medulla to pull out the water, which would concentrate your urine. So what happens is loop diuretics don't allow you to have this water leaving in the collecting tube, which is that final fine tuning. So you actually end up having a lot of really undiluted or low osmolality urine, which makes sense because loop of Henle diuretics or Lasix are much more potent in bringing fluid off. And that's one of the reasons that they are. It's not because of where it affects the nephron specifically, it's actually because of that effect of decreasing the salty medulla and turning off or making ADH basically ineffective. And due to it being ineffective, you'll pee out more volume, and more volume, less dilute, lower osmolarity. More dilute, I should say, less osmolarity. Whereas with the thiazide diuretics, you don't have that effect. In general, the RAS system is to protect you from hypotension and death from hypotension. Hypotension, if you had to take one or the other, you would take hypertension as opposed to hypotension. So the RAS system is much more favored, and in fact is solely something used to increase your blood pressure, which is why it has a tendency to inappropriately be turned on in certain states and cause things like more edema, more hypertension. So I would really just keep it simple and say, if you have low blood pressure, you have sensors in your actual blood vessels, the baroreceptors, which will turn on RAS and turn on catecholamines themselves. And then within the nephron itself, you have that juxtaglomerular apparatus and the macula densa that will work together to see increased flow or decreased pressure just coming in, right? Decreased pressure of the arterioles coming into the glomerulus. And together, those effects will combine to turn on RAS, to increase the amount you're absorbing from the nephron, to increase vasoconstriction, to turn on aldosterone, to turn on ADH. They all work in conjunction with each other. So I would say that what I would say is RAS gets turned on by two things: low blood pressure or low EABV, which are pretty close to the same things to each other, and increased distal nephron flow, because your distal nephron senses that and is worried that you're going to pee out too much salt and water and get dehydrated and die from hypotension. Then the RAS system does all of those things to counteract it. It releases a bunch of different hormones, including angiotensin, aldosterone, ADH, and each of those different things have different effects on the blood vessels, the kidney, proximal tubule, the loop of Henle, the collecting duct, the ADH, the collecting duct via ADH and aldosterone, and all of those have the same effect to try and increase your blood pressure and keep you alive. Does that make sense, Anna?
Yeah, that made it a lot easier than trying to figure it out off of the physiology textbook, so thank you.
Yeah, like sometimes it's nice to get into those nitty-gritty details just to say like, hey, like I get how this works and why it works now. But when it comes to like helping you out on a test or helping you out clinically. Really, all you have to know is like there's a few different ways to turn on RAS. When RAS is turned on, it uses a bunch of different hormones, and its main goal is to increase its blood pressure through those hormone signals. Okay. So if there's any other questions, happy to answer them. Let me see in the chat. Okay. So I think there's not too many more questions. There's not too many left on you. What I'll say to the few people that are left is thanks for listening and staying longer. I'll try to be better with my time management and at least warn you guys how long we're going to actually go. I'm thinking of doing a diabetes one on Monday night. So Monday night, keep a lookout over the weekend, and we'll get everything out for you guys to get set up for a Zoom meeting then, and we'll go through diabetes in detail because I know it's a big thing on your test. And yeah, all I would say is feel free to message me or message Dr. Bessiuni. Probably me is honestly the easiest way. Through whatever mechanism is fine. I don't mind. And then if you have a specific topic that you want to cover within diabetes or future topics, then we'll definitely address those. Okay. So I'm going to stop sharing and recording, and I'll get this recording out of this session out as soon as I can figure out how to make that happen. Okay. And the slides are posted on Facebook, but I'll also, once I get the recording figured out, I'll get the slides out there as well, just in terms of the slide document. All right. Hope you guys have a good evening. Have fun this weekend.